Lovely to have you on. Um, I've been asked to just do like a 1 hour lecture discussing two conditions that we manage quite frequently in pregnancy. So that's diabetes and preeclampsia. So I've kind of done it around a couple of cases and kind of we'll just work through how these patients can present and kind of the management that we would usually offer. So I'm really happy for anyone to interrupt me whilst I'm giving the lecture. And like I said, if there's any questions, I can't see hands and things. So either just shout out or pop it in the chat, and then hopefully we can see that the question's been asked. Okay, great. So this is the first case. So this is Sophie. She's a 40-year-old primate, so in her first pregnancy, and she's come to an antenatal clinic appointment. She has a BMI, a body mass index of 39, and she currently smokes 10 cigarettes per day. At the booking appointment, they had arranged for her to have serial growth scans. And at 26 weeks, she had a 2 hour oral glucose tolerance test, which came back with a 2 hour result of 7.9. And so she was diagnosed with gestational diabetes. She then went to her growth scan at the 32 weeks appointment, which revealed that the baby's abdominal circumference was more than the 97th centile. She then had a repeat scan at 36 weeks, which revealed that the baby's AC was still above the 95th centile, and her blood pressure now was 138 over 85 millimeters of mercury. So this is just a growth scan, not hers obviously, but just to give an idea. So when we're doing the growth scans, we're looking at three things which essentially come together and give us an estimated fetal weight. So we're looking at the head circumference, the abdominal circumference, and the baby's femur length. And you can see there between the 32 and the 36 week scan that the baby's abdominal circumference has kind of accelerated in the growth compared to when she presented much earlier on with her booking scan at around 21 weeks. So again, here's just a sample of what we would then, if we were to plot it on, some hospitals use what's called like a customized growth chart. And that takes into consideration the mum's ethnicity, her height, her weight, and then plots where they think the baby should be in terms of size. So you can see here that her baby is heading towards kind of the 90th centile. So it's quite a big baby on scan. So just a bit of questions and so interactive. Anyone just shout out what in Sophie's history makes her pregnancy high risk? Yes, exactly. So age being 39. Yep. Anything else? So I can't see your responses. So please feel free to just shout as well. Yep. So the diabetes, yes, her BMI of 39, all risk factors for the pregnancy. Yes, smoking. Exactly. And one more thing I've got on a couple more things actually. Is a pregnancy higher risk the first time or the subsequent times? Exactly, yeah. So, like most things, people usually behave however they have been behaving. So, the first pregnancy is quite high risk because we have no history. We don't know how your body does in pregnancy, how it does in labor, how it does kind of in the postpartum period. So, it's all very high risk because we don't know and we have no history to know how you're going to behave. So the first pregnancy is always slightly higher risk. But if someone goes through their pregnancy and labor and it's all smooth sailing, then we kind of are happy that the pregnancies going forward should follow suit and should do the same thing. So the first is always a little bit higher risk. And the final thing is the baby's size. So that just makes it slightly higher risk. So she's potentially now got what we call a macrosomic baby. So this baby is more than the 90th centile on scan, which we'll talk about what the risks are. So who is it that we screen for diabetes? Does anyone know kind of? Okay, so you screen all your pregnant ladies. Okay. So it might be different. So all your pregnant ladies are screened for diabetes. That's interesting. So I guess because of where you are. So yeah, so here in the UK, I guess because the ethnicity mix is different. So we would only screen people who have a family history of diabetes. So their first degree. Yes, if previously in their pregnancy they'd had diabetes. If they had a baby that was big in a previous pregnancy, so if a baby weighs more than 4.5 kilos, we screen them for diabetes because we feel we probably missed diabetes in that pregnancy. Other things are ethnicity. So all our Black and Asian ethnicity patients are also screened as well. And anyone with a BMI over 30 also is screened for diabetes. So from the history I've given you about Sophie, can you think about what kind of medications and things we will want to be considering for her antenatally? So potentially, yes. So we would usually start people on metformin, so oral anti-glycemic control first. So we usually start with metformin, but if we are struggling to control their diabetes with the metformin, then yes, the next line would be go on to insulin. Yeah. So that's the main thing for her diabetes. The other things to consider, which are things that we do here in the UK, is that because she is 40 and it's her first pregnancy, she automatically is deemed high risk for pre-eclampsia. So we would offer her to start aspirin from when she becomes 12 weeks in her pregnancy all the way till she's 36 weeks. And that's as a preventative for developing pre-eclampsia. The other thing we would consider, again, unfortunately, living with the UK and not much sun, we would offer her vitamin D supplementation. So anyone with a BMI over 30, and we worry about their ability to actually absorb the vitamin D. So it's recommended that they are on vitamin D and also high dose folic acid for the first trimester, and then continue the vitamin D throughout the pregnancy. And then finally, we do a risk assessment for anyone that might be at risk of developing clots in their pregnancy. So she has some risk factors in her pregnancy that potentially she may need fragment, so that the low molecular weight heparin. So the fact that she's over the age of 35, the fact that she has a BMI over 30, and the fact that she's a smoker gives her 3 risk factors. So in her case, we would advise her to inject herself with low molecular weight heparin from 20 weeks until delivery, and then for 6 weeks after delivery to prevent the risk of venous thromboembolism. And what are the kind of reasons for why we would offer people serial growth scans? So again, just to put context, here in the hospital I work in, we would only offer a scan at 20 weeks and then another one at 36 weeks. But there are additional things in people's pregnancy that might make you want to give additional scans. So just want to have a chat about that. What kind of reasons would you think about? Yeah, absolutely. So anyone that has gestational diabetes, as well as obviously type 1, type 2 diabetes, they're always offered additional growth scans throughout the pregnancy. And like you said, to rule out in particular macrosomic babies. Other things are people with high BMI. So some hospitals will offer them because the only alternative way of checking how a baby is growing is doing the symphysis fundal height. And obviously in women that are larger, where actually there's more adipose tissue, it's less likely to be accurate. And so we do offer those women additional scans. We also offer smokers additional scans because of the way that the smoking can affect the placenta. And so they are likely to get small babies. And then the other group are those with hypertensive disease. So anyone with either pregnancy-induced hypertension, preeclampsia, if we've got concerns about the growth, we can also offer some additional growth scans. So that's great. So you've got all the risk factors that we discussed. So just a brief about diabetes, in particular gestational diabetes. So essentially, why women develop diabetes in pregnancy is because of various hormones in pregnancy, so estrogen, progesterone. But then additionally to that, there are hormones that are produced by the placenta. So human placental lactogen, growth hormone, and all these things together actually create a state of insulin resistance. And so they get high levels then of glucose in the body because the insulin isn't functioning. And so as a result, they then develop diabetes in the pregnancy. So as I mentioned earlier, we test for diabetes for all these various things. The other additional thing I forgot to mention is anyone that has glucose in their urine. So if we dip your urine at an antenatal clinic, if you have 2+ or 1 on one occasion, or if you present to us twice with 1+ of glucose in your urine, then again we would suspect underlying diabetes and screen you for that. And the way we test for it is by doing a glucose tolerance test. So women are asked to take a fasting glucose level, and then they drink a horrible sugary drink. And then 2 hours later, we test the sugar again. And the diagnostic kind of thresholds are either a fasting glucose level that's above 5.6, or 2 hours later, if it's above 7.8. And then we would then diagnose that person with gestational diabetes. And so we've talked about already the things that we would offer in pregnancy. So like I said, this is the taken from the NICE guidelines. So these are women that are deemed to be at high risk of pre-eclampsia, and we would offer them 150 milligrams of aspirin from 12 weeks. So you only need to have either one thing from the major risk factors. So that's the top stuff. So people with already pre-existing hypertensive disease, chronic kidney disease, autoimmune diseases, type 1 and type 2 diabetes, and chronic hypertension. And then you need 2 moderate risk factors. So that's being your first pregnancy over the age of 40, a pregnancy interval of more than 10 years, BMI over 35, family history of preeclampsia, or those that are having twin, triplet pregnancies. And then again, this again can be found on our Royal College website. And this just is the risk assessment that we carry out for all women in our clinics. So if the left part of it is what we do in the antenatal period, and on the right-hand side, you can see what we do in the postnatal period. So depending on someone's risk score, they will be deemed either they need low molecular weight heparin or not. So how do we manage women with gestational diabetes? Like most things in medicine, we always start with the basic things. So that's diet and lifestyle. So we really try and encourage our women to think about weight management. Now, if somebody developed diabetes in their pregnancy, then what we should be doing is kind of pre-counseling, preconception counseling for their next pregnancy, and say to them, actually, it's really important going into your next pregnancy that you really bring your weight down to below a BMI of 30, because that's going to really help to prevent you getting diabetes in any future pregnancy. So that's really important, encouraging kind of regular exercise, thinking about their diet and what they're eating. And if anybody is struggling with their diet, then we can always think about, do we need to involve like dietitians? We've talked about how it's tested. And then, like you all mentioned rightly, we would then, if we had to think about medical management, that would be using either metformin, is the kind of oral hypoglycemics we use in pregnancy that's deemed safe. And if that doesn't work, then we'll be thinking about insulin. So let's have a think now about what are the risks to mum and baby in those with gestational diabetes. Can we think of any risk factors? So you've mentioned one of them, which was that the risk of big babies, so macrosomia. Yeah, that's right. Preterm delivery, yes. Yeah, so yep, shoulder dystocia, exactly. So having big baby, yep. So we know that the placentas in diabetic mums are just not working as well. So we do worry about, especially towards the end of pregnancy, there is an increased risk of stillbirth. Any more for the baby? You've mentioned shoulder dystocia. Yes, exactly. Congenital anomalies. Now, congenital anomalies tends to be more in people with pre-existing diabetes. Yep, neonatal hypoglycemia, absolutely correct. So congenital anomalies is rare in someone with gestational diabetes, but definitely for pre-existing type 1 or type 2 diabetes, that definitely is a risk factor. Um, I will go on and then ask the other questions. How would you think about managing these women? So we talked about antenatally. We said that we'd think about what are their risk factors. We'd think about how we should be managing them to treat the diabetes. So either is this somebody that we can just control with diet, or is this somebody that actually we need to put on insulin? Then what about in labour? So you've talked briefly about what some of the risks. So are these women that we want to deliver happy for them to deliver at home, or would you want them delivering in the hospital? Absolutely, yeah. So we want them delivering in the hospital, and we want them on here we have like continuous monitoring. Exactly. So what we usually do for gestational diabetes is that we think about delivery by 41 weeks. Now, if it's again pre-existing diabetes, that's slightly different. So type 1, we would be thinking from 37 weeks. The only time with gestational diabetes we'll be thinking about delivery at 37 weeks is if they were on insulin. Because if they're on insulin, we treat them almost like a type 1 or a type 2 diabetic. But if they were just diet controlled, we can actually allow them to go to 40 plus 6. And we would want them continuously monitored. We would be worried about, like you've mentioned, shoulder dystocia in their labor, how the baby responds to labor. And then postnatally, we've talked about some of the risk factors for the baby. You've mentioned neonatal hypoglycemia, so it's really important to check the sugars of the baby. The other thing is, obviously, when mum develops gestational diabetes, that's kind of a trigger that actually she is at risk of developing full-blown diabetes, type 2 diabetes in her lifetime. So it's like a warning for mum. So we actually follow these women up annually, and check that they're not developing diabetes. So that's really important to have that lifelong screening to make sure they don't develop actual diabetes. And we talked about the risks in labour. Yes, someone mentioned RDS. Yes, that's absolutely, that's a risk factor for baby. So again, this is just kind of the hypothesis of what happens in kind of the etiology of gestational diabetes. So you get maternal hypoglycemia because you've got this state of insulin resistance, and then baby gets hypoglycemia and then gets hyperinsulinemia, and then these go on to cause all the various things that you've mentioned. And so these are some of the risk factors that we'd expect to kind of be discussing with the women in clinic. So the maternal risk factors are at risk of pre-eclampsia, risk of miscarriage and preterm birth, as you'd mentioned, higher risk of needing intervention. So that's either with instrumental delivery, with forceps or a ventouse, or with a cesarean section. Higher risk of infection, and like I mentioned, higher risk of kind of future diabetes for them. And then in terms of the fetal risks, whilst in utero, you've mentioned about big babies, higher risk of stillbirth, and also you can get increased amniotic fluid in the pregnancy, which again can put you at risk of preterm birth. And then the neonatal risks, again, you've mentioned some of these. So shoulder dystocia is the real one we worry about, especially with these macrosomic babies, which in turn can lead to kind of birth injuries. There is a risk of electrolyte imbalance for these babies, jaundice, respiratory distress, polycythemia, and then they need sometimes admission to NICU just to help with those things. And why it's so important for us to intervene is that you can see here from this graph that when women have gestational diabetes and we don't intervene, you can see what the rates are there of adverse outcome versus when we do intervene, and why it's really, really important that we do try and intervene, because it does reduce adverse outcome. The one that's obviously significant on that is the birth weight of the baby. Other things are reduced, but obviously they're not showing as significant, but they are all causing a reduction in adverse outcome. And we talked about shoulder dystocia, and that's where the baby's anterior shoulder is stuck behind the mother's pelvic bone, and so that makes difficulty in delivery. You can see here just a picture. So we've got the big macrosomic baby next to kind of a normal size baby. So it's you can imagine what that can do for mum. Okay, that's great. So we've done gestational diabetes. Move on to case 2 now, which is again diabetes. I know I was going to do just gestation, but I thought I'd briefly talk about type 1 diabetes as well. So Helena's a 21-year-old, again in her first pregnancy with type 1 diabetes. She has a history of difficulties with treatment adherence, and she actually developed some kind of microvascular complications and suffered 2 miscarriages earlier on in the year. She has this time worked really hard to stick to her insulin regime and has better glycemic control. And she's presented to her GP now 8 weeks pregnant. She has got some mental health history, and that's all kind of adding to the anxiety. And she's really worried about how the diabetes is going to affect this pregnancy. She's been religiously checking her blood glucose, and then she presents through our emergency department at around 20 weeks via ambulance now with a reduced GCS and a glucose level of 2. So firstly, what is the diagnosis? Any ideas? So for mum, just hypoglycemia. Yeah. So hypoglycemia, because she's presented with a glucose of 2. Not necessarily encephalopathy yet, because although she has a low glucose, by the time we hopefully correct it, but yes, she is obviously present with a low GCS and secondary to her hypoglycemia. So do we know kind of what we can be using to improve glycemic control in pregnancy? So obviously we have the involvement of our endocrinologists to make sure that we can make sure that their sugars are all okay. And but otherwise, some women are really fortunate to have these like insulin pumps you can see here, which give you kind of continuous glucose control, and it's better at fixing it. So how do we treat hypoglycemia? So someone there mentioned dextrose, I think. Yep. So with anything, someone presents acute. So we always use what's called an A to E approach. So A, B, C, D, E. So the first thing would be to check her airway. Is it patent? Is she talking? Is she breathing? Are you happy that her heart rate is fine? Is her chest moving equally? What's the pulse? What's the blood pressure? And then when we move to D, that's where we're thinking about disability. So if we recognize that this is hypoglycemia, this is where we would then be treating. And the treatment all depends on whether or not this patient is alert or whether they're unconscious. So if they're alert with a low glucose, we can just give them a very sugary drink and a carbohydrate to bring the sugars up. If, however, they're unconscious, and we're worried, obviously, that they're going to aspirate and not going to be able to tolerate something orally, then, as you rightly said, we need to be giving them some form of dextrose. So usually we use 20% and alongside fluids with some potassium in it to try and bring their sugars up. So we use 20% glucose usually over 15 minutes. And with some running fluids as well to bring their sugars up. And they would be on some kind of like regular sliding scale to make sure the sugars came back up. And then in terms of what we would be doing additionally for her antenatally is just making sure that she's adhering to her regime and that we have got her on the correct amount of insulin. And there's some additional things that we do for people with diabetes. So type 1 and type 2. So I'll go on to that. So this is just, as I mentioned, there is a flow chart there you can see about how we manage hypoglycemia. So it's exactly the same for people that are pregnant and non-pregnant. We manage hypoglycemia exactly the same way. So as well as their routine checks, anyone with pre-existing diabetes gets a retinal screen where we check their eyes to make sure there's no evidence of retinopathy. So we usually offer that, like I said, within kind of the first trimester and then again in the third trimester. We think about their kidneys. And so we regularly check their kidney function and make sure that they're not have like too much protein, their creatinine's not too high. We've talked about preventing preeclampsia. So these women will automatically be put on a pathway of starting aspirin from 12 weeks to prevent preeclampsia. And as you said, they are at higher risk of congenital abnormalities. So we'll be offering an additional kind of really detailed ultrasound scan looking at a 4-chamber view of the heart, as well as the serial growth scans. And here again, you can see some of the complications that we see in diabetes compared to the background population. So it's a really big thing having diabetes in terms of your complications for pregnancy. And these are some of the common congenital abnormalities that these babies are at risk of. So it's really important that these group of women are on high dose folic acid, preferably pre-conception. And that's to prevent against things like anencephaly and spina bifida. There's also a risk of sacral agenesis and limb defects. It can affect the renal system of the baby, so renal agenesis, hydronephrosis, and ureteric abnormalities. Can also affect the heart. So in particular, looking at ventricular septal defects, atrial septal defects, and cardiomyopathy. And then in terms of their gut, we're looking for things like duodenal atresia, anorectal atresia, and small left colon syndrome. So those are things that our sonographers would be looking at in more detail in a woman with diabetes. So that's diabetes. So just to finish up, so the final case is Nadia. So she's a 35-year-old, again, primip, who is presented to us at 32 weeks. So she's presented very late into her pregnancy. She's referred to the high-risk pregnancy clinic because she was a late booker. And she's recently arrived from Sudan claiming asylum. And she's living in a house with her husband and sister-in-law. At the clinic appointment, her blood pressure was 150/90. But unfortunately, she had quite limited English, so the midwives were unable to work out whether or not she had had high blood pressure in the past. But she herself said she feels quite well and didn't have any of the symptoms of preeclampsia. And at the end of the appointment, they rechecked the blood pressure again, and this time it was 140/85, so it's slightly improved. So they thought, well, maybe this is just a bit of anxiety and not true high blood pressure. Her BMI was also recorded as high, 36, but baby's heart rate was fine. She was then booked to have a growth scan and come back to the antenatal clinic for review in 2 weeks' time. So then a few days later, she presented to our maternity assessment unit via ambulance with a blood pressure of 160/100. And she had a proteinuria level, so PCR of 200, and was complaining of a really severe frontal headache. So what is the diagnosis? Yeah, preeclampsia, absolutely. So we've got, yeah, exactly. So this is severe preeclampsia, isn't it? And how do we reduce the risks? We've talked about earlier on with diabetic patients. How can we reduce the risks of preeclampsia? So that's recognizing our women who are high risk and starting them on aspirin from 12 weeks in the pregnancy can reduce the risk of developing preeclampsia. And then we're just going to talk about the medications that we use to treat it. So yeah. So we do, yeah. So if they're deemed, we usually say a blood pressure every time they see their midwife. If they are deemed to be slightly higher risk, then we may do it more frequently. So maybe every 3 weeks to check that the blood pressure is stable. So what is preeclampsia? So as you've rightly said, so preeclampsia is anyone presenting with a blood pressure of 140/90 millimeters of mercury. And also they need to have a proteinuria of more than 30. And in addition to that, some women, so those are the two main things that you need. And this needs to be after 20 weeks. Otherwise, it's classed as chronic hypertension. And in addition to this, some women may go on to develop organ dysfunction, so particularly their kidneys or their liver, or there might be signs of placental dysfunction. And so actually they may just present with a very small baby and with abnormal Dopplers when they're scanned. And we go on to call it eclampsia if all of this is happening. And in addition to that, the woman presents with seizures. So that's when we call it eclampsia. And the main concerning features for us with preeclampsia are systolic blood pressure that's above 160, very high creatinine, high evidence of liver dysfunction, so your ALT there being more than 70, and a platelet count of less than 150, which is obviously showing signs of hemolysis. So there's two stages, obviously, to how we think preeclampsia comes about. So there's the abnormal placental, how it implants, placentation, and so you get this abnormal trophoblastic development, and so that can cause placental ischemia and hypoxia. And then the other stage of preeclampsia is this imbalance between PIGF, which are the kind of pro-angiogenic and anti-inflammatory hormones, and then SFLT, which is more anti-angiogenic and pro-inflammatory. And so when there's a mismatch in that, that balance can lead to endothelial dysfunction, and then you get preeclampsia. So how do we reduce? We've talked about, like I said, identifying our women that are high risk. So anyone that's high risk, we would start on aspirin, and that helps with the stage 1 aspect of preeclampsia when the placenta is implanting. So that can really help with that stage. The second stage is like a screening we can offer. So we can look to see if there is this balance between the placental growth factor, and that's trying to detect early people who may be at risk of preeclampsia. So we can see there that when the placental growth factor is less than 12, that test then is positive, and it's highly abnormal and suggestive that there is severe placental dysfunction and there is an increased risk of preterm birth for that woman. So the management, the first thing is to bring down the blood pressure. So we want to aim for a blood pressure of less than 135/85. And we do that by starting with the usual kind of antihypertensives, which are labetalol, which is a beta blocker. So the only women we would obviously not be using that in is women with that are asthmatics. Nifedipine, a calcium channel blocker, and then methyl-dopa. The only thing about methyl-dopa to be aware of is that we can't use it in the postnatal period. So people don't tend to really use it anymore in the antenatal period because it is associated with increased risk of depression if it's used in the postnatal period. Like again with everything, diet and exercise. So especially if this woman has a high BMI that's contributing, if there's diabetes involved that's contributing to her preeclampsia, we need to think how we can manage those things to improve her blood pressure management. And then keeping an eye on baby, because obviously there's another person involved with preeclampsia and is affected by this placental dysfunction. So we just need to make sure that baby is not too small. If a woman presents in very severe preeclampsia with severe hypertension, like the lady in our case, then you need to also be thinking about, actually, is it safe to give her just oral antihypertensives, or do we think we need intravenous ones as well? So we can give women IV labetalol, we can give them hydralazine, which works much better to bring down blood pressure. We need to think about preventing eclampsia. We do that by giving intravenous magnesium sulfate. And if we're really worried about this woman's preeclampsia and we think we might need to deliver her baby, then we need to be thinking about, do we need to help with the lung maturity of the baby, and think about antenatal steroids. So we would give steroids intramuscularly, 12 milligrams, either 12 or 24 hours apart. If we're thinking about a vaginal delivery, that would be up to 35 weeks. If we were planning a cesarean section, then we would offer that up to 37 weeks. And those are my references. So I am going to try and stop sharing now. Okay, that's it. Any questions?
Great. Thank you so much for doing that. That was, yeah, really, really useful. And I think the cases were particularly good to work through. So yeah, thank you so much.
That's all right. No problem at
Um,
all.
and yeah, we've recorded it, so we'll send out the recording after the session as well. But thank you everyone for coming.
That's no problem at all. Okay. Okay, great. Thank you so much. If no one has any questions. Thank you.
Thanks.
Bye. And same to you. Have a good day. Bye-bye.